just short of quorum, but we are going to get the Health and Human Service Reform Committee to order. The first bill up this morning is House File 1712, Representative Pierson. And when we get the bill in front of us, we will move that this bill move to the General Register. But until that time, Representative Pierson, welcome to the committee. Please present your bill.
Thank you, Mr. Chair, and thank you, members of the Health and Human Services Policy Committee. The amended language in House File 1712 was derived from a large stakeholder group that started meeting in November of 2015 to develop changes to the limited authorization dental hygiene legislation to reduce barriers to better utilize this profession. This profession provides dental hygiene services in community settings like schools, Head Start programs, and long-term care facilities under the supervision of a dentist to reach Minnesota's most vulnerable and underserved patients. These changes are needed in legislation to ensure that dental hygienists in a collaborative practice can develop and implement sustainable practice models to reach underserved populations. This legislation does not change the procedures that dental hygienists are able to provide, but reduces barriers to allow them to provide their currently approved scope in settings outside of the clinic that are convenient for patients and align the scope in statute with the licensure rules at the Board of Dentistry. Mr. Chair, I have Gene Anderson with the Minnesota Dental Hygienists Association to describe the bill and provide testimony.
Welcome to the committee, Ms. Anderson. If you could please state your name for the record and present your testimony.
Yes, Mr. Chair and members of the committee, my name is Jean Anderson, and I've been a dental hygienist for 45 years as a clinician and educator, and currently I'm the clinical director of a school-based program that serves children in need in Minneapolis schools and preschools. We employ a collaborative practice hygienist, a licensed dental assistant, an advanced dental therapist, community health workers, and we have a group of volunteer dentists who help us provide services. This bill is going to make a difference to us as many other organizations that utilize hygienists with collaborative agreements. You can see by the letters of support some of those organizations for yourself today. We, of course, support House File 1712, as Representative Pierson said, because it will remove barriers and feel that more dentists and dental hygienists and dental assistants will engage in this model. Collaborative practice legislation was passed in 2001, which to me seems like yesterday, but was quite a long time ago. And since then, it's been tweaked a couple of times, but it really needs a rebirth because it's sorely underutilized in this state. I won't go into statistics unless you want them, but a very, very small percent of dental hygienists, even though they have collaborative agreements, are not fully utilizing them. The key points for you, I'm sure you've received the handout that's in your packets. I'd like to draw attention to that group of stakeholders and also committee members that were reconvened in November of 2015. And I won't say it's unprecedented, but what I would say is I've sat on many committees on initiatives like this, and I have never been a part of this group that's agreed and come together. So it's very enlightening. It's very exciting that we could collaborate all together and come up with this language for you today. What the bill does is, like I said, is it encourages more dental professionals to engage in this model and remove some of those restrictions. Some of the duplicative language is being removed because it is already mandated by the Board of Dentistry, such as the requirement for CPR. And the requirement for documentation and record keeping is also in rules, so there's a reference to that. I think a big part of this is that it references rules, and so the statute doesn't have to list any more all of the services that can be done by dental hygienists, but just refers back to the rules 3100, 8700. It also clarifies the referral system that's very important for these patients for follow-up care. So it really mandates what the dental hygienist and dentist must do for follow-up care. And lastly, we recognize that the licensed dental assistants that we employ in these models are underutilized and stand by while they could be providing services that they're already licensed to do. For example, fluoride treatments. And many of you might know that in the medical community, they can provide fluoride treatments, and even someone who takes the online course can provide fluoride treatments, but the dental assistant's hands are tied. So while our dental hygienist just merely is assisting, she could be doing services on these children and increasing the number of services that we provide on a daily basis. So it's really an important piece. And I want to thank you for hearing this bill, because I think it's a piece of the solution of really achieving better access to care. And this is the first phase. We need this legislation in order to move forward, and using resources from this committee and a HRSA grant to educate hygienists and get them to engage in this model by teaching them the how-tos. So we need these changes to begin that process. So thank you very much for your time, and I look forward to your affirmative vote and any questions you might have.
All right, thank you, Ms. Anderson. And we now officially have quorum, so I will officially call the meeting to order and move that House File 1712 be referred to the General Register. Representative Pierson, you have the A1 amendment. To your A1 amendment, I'll move the A1 amendment.
Thank you. It just gets the bill in the proper order.
All right, are there any questions on the A1 amendment? Seeing none, all those in favor of the A1 amendment signify by saying aye. Aye, opposed, same sign. The A1 amendment is adopted. Representative Pierson, to your bill as amended.
We have no other testimony. We'd be happy to answer.
All right,
any
are there any
questions.
questions for Ms. Anderson? Seeing none, is there anyone in the...
Here's one here.
Oh, Representative McDonald, didn't see you over there. Sorry about that. Representative McDonald.
Thank you, Chair. A question for the testifier. Is there a cost savings then for this?
Ms. Anderson.
The cost savings is in utilizing the dental hygienist, who is really off-site of where the dentists are. So it would cost much more to have a dentist do these services. So the more services we can do, there's cost savings there, as well as utilizing the dental assistant.
Representative McDonald.
I would presume so thank you.
Yes, you're welcome.
Is there anyone else in the audience who wishes to testify in House File 1712? Seeing none, final questions from members. Final word, Representative Pierson.
Just that the bill does not change the procedures that dental hygienists can perform, but it aligns the statute with the licensure requirements at the Board of Dentistry.
With that, I'll renew my motion that House File 1712 as amended be referred to the General Register. All those in favor signify by saying aye. Aye, opposed, same sign. The motion prevails, and House File 1712 as amended is referred to the General Register. Thank you, Representative
Thank you,
Pierson.
Thank you.
All right, next up is House File 1132, Representative Backer. And as he's making his way and settling in at the testifier table, I will move that House File 1132 be re-referred to the Committee on Health and Human Service Finance. We have the bill in front of us. Representative Backer, to your bill.
Yes, Chair and members, thank you for the opportunity to share House File 1132. This bill does one simple thing in the statute for PCA services, and it removes the word constant. That's all this bill does, one word. But it's going to have a big impact. In 2009, due to budget issues, changes was made to the PCA program to limit the eligibility, which was phased in over time. It did result in many children and adults with mental illness being removed of this important program. Changes included requiring 2 dependencies instead of 1 in activities of daily living, adding the word constant to supervision. The problem for people with mental illness is they don't always need constant supervision. There's times that people will come to the room or to their living area, apartment, home, whatever it may be, and they just need help to make sure they take the right meds today. Or they get too much mail and it gets too much for them. But those things are very important. As an EMT, I know when those people break down and run into other challenges, then they call 911, and then I respond, and that's the most expensive care. Putting the word, removing the word constant really allows the assistance to people who don't need constant care, but they need some type of a little supervision. In the 2015 session, we passed legislation requiring DHS to determine who was cut off from the PCA services due to this change. Their report estimated 1,837 people would become eligible if we got rid of this one word. And with me here today, I'll turn it over to my testifier.
Welcome to the committee, Ms. Abder-Holden. If you could please state your name for the record and present your testimony.
Great. Good morning, everyone. Sue Abder-Holden, Executive Director of NAMI, Minnesota. So really, this is that simple, that we're getting rid of the word constant. And again, if you think about people with mental illnesses, they don't need hands-on assistant to eat or to cook or to do those kinds of things, but they might need supervision, they might need cueing. So, okay, let's, what have you got in your refrigerator? Those kinds of things. Helping them with the day-to-day activities of daily life, that can be really difficult. I think what's interesting is that in our eligibility for determining nursing home level of care, we do not have the word constant. But for this inexpensive form of care, we do have the word constant. And so I think it's just interesting that we do that way. I know there is a fiscal note to this, clearly, but we just want to keep this issue in front of you, that the kind of the least expensive form of care is something that many people with mental illness are no longer eligible for. Thank you.
Thank you, Ms. Abder-Holden. Are there questions for the testifier? Seeing none, is there anyone in the audience who wishes to testify on House File 1132? Seeing none, any questions, final questions from members for the bill author? Final word, Representative Backer.
Thank you for your consideration, and we just want to remove one word.
With that, I'll renew my motion that House File 1132 be re-referred to the Committee on Health and Human Service Finance. All those in favor signify by saying aye. Aye. Opposed, same sign. The motion prevails, and House File 1132 is re-referred to the Committee on Health and Human Service Finance. Thank you, Representative Backer.
Thank you, Chair and members.
Albright, next up, House File 1130, Representative West. And as he's making his way up, I will move that House File 1130 be re-referred to the Committee on Health and Human Service Finance. We have the bill in front of us. Representative West, welcome to the committee. Please present your bill.
Good morning, Chair and committee members. House File 1130 is a $75,000 appropriation to assist Anoka County in recruiting foster families. Right now, we have 25,000 children in foster care, and in Anoka County, we've seen a 70% decline in foster families. So they approached me with this bill, and I think it's great to get a little effort started to try and increase membership in foster families so we can get people to take care of these kids. And I have two testifiers from Anoka County to go into more detail.
All right, welcome to the committee. If you could please state your name for the record and present your testimony.
Yes, Mr. Chair, members of the committee, I'm Jerry Pierson, Director of Social Services and Behavioral Health in Anoka County. I'm here with Lisa Welter, Community Care Director from Eagle Brook Church. Thank you for the opportunity to talk about this bill. Anoka County staff have always been encouraged to think outside the box when it comes to helping our residents. House File 1130's goal is to identify and enhance family foster care recruitment and provide some administrative simplification through local non-traditional partnership efforts. As many of you may be aware, there is a statewide decline in accessible family foster care. Anoka County alone has experienced over a 70% decline in available local family foster care over the last several years. Although there is a statewide shift to relative care, the demand and need for non-relative care still exists. Current recruitment models have not been extremely effective in keeping up with the foster care demand for non-relative care. Our bill does not attempt to address all the issues related to traditional foster care. Our plan has been to engage with local non-traditional partners to produce a sustainable and replicable model for family foster care recruitment. We've been engaged with a large faith-based organization who has stepped forward in this effort. They have been providing a receptive audience to our recruitment needs, but have also brought other partners to tackle this problem as well, including Department of Human Services and other private agencies and licensing agencies. Lisa Welter is here with me today as our partner to express why this effort is so important and the potential it has. So, Mr. Chair.
Welcome to the committee, Ms. Welker. If you could please state your name for the record and present your testimony.
Thank you, Mr. Chair and fellow committee members. I want to personally thank you for the opportunity to be here to support Anoka County's innovation. My name is Lisa Welter. I'm a pastor at Eagle Brook Church. I lead a large ministry called Community Care. And at our faith community, we have this opportunity to address large volumes of attenders and take very complex messages and simplify them, which makes us very relevant and applicable in our communities. Today, I'd like to share our story that has led to a surprising innovation surrounding foster care while leveraging non-traditional partnerships. The hallmark of our success has been collaboration. Last year, over Easter, I made my way out to the Lino Lakes Juvenile Corrections Facility. I was delivering hot chocolate and donuts to the youth and their staff, and while I was on site, I learned of a 12-year-old who was a foster youth and had been there since the previous fall. 8 months is too long, and yet this was the reality of an overwhelmed system doing the best they could with the resources that they had, and the unintended ramifications of children not launching well into adulthood. As a pastor, it took me a while to connect the dots, that our society's challenges connected greatly to the way the community responded to child welfare systems. I polled area agencies addressing niches of child welfare from early intervention to youth transitioning into their young adult years, and I was fascinated to learn that no one was really collaborating, not because they didn't want to, they were simply drowning in the demand and didn't have time to consider a different way. I saw this as an opportunity as an area church leader and was convinced that the faith community could find a way to wrap around our area agencies, but it had to be simple, it had to be applicable for the majority of our faith communities and not just to the 1% of our attenders. And it had to be developed in a way that was comprehensive enough to see true change rather than creating another problem. I brought Jerry from Anoka County, Save Families for Children, who does early intervention, and the YMCA, who provides host homes for youth, together to do just that. We tested a formula across the spectrum of child welfare at our two of our locations, and we recruited for homes, early intervention homes, foster homes, adoptive homes, and host homes for youth transitioning. And then we invited those to wrap around those homes with resourcing, basic needs, meals, transportation, babysitting services. And then a piece called independent living. How could we help these kids launch? We did this at 2 campuses, and here's what we found. The local church cares deeply about hurting kids, about foster youth, and about our wards of the state, orphans. And her people spring into action when opportunities are clearly presented and barriers are removed for engagement. We've simply been stuck in a rut, holding food drives, school backpack drives, all transactional in nature and simply touching the community's symptoms condition. Most of us not truly getting close to the root of the problem in child welfare, simply because we just didn't understand the problem. However, when a faith community is educated and provided with easy on-ramps to engage, she will not turn a blind eye to these kids, and she simply won't and has not when you look historically at international development and orphan care. The results of our beta tests were surprising, but I want to give you some context of typical church engagement. I mentioned backpack drives and food drives, and in the past, in my context, we've seen 10 to 20% of the faith community participate. When we presented this new formula with simple pathways to engage across the whole spectrum of child welfare, homes and resourcing, we had an 80 to 85% response rate. We had 90 people step forward to open their homes. We had 100 families and small groups saying that they would resource. There was something for everyone. Now, I'm not an expert in business, but I'm aware that this sort of participation is unheard of and has enormous potential to change a community's landscape. Because of the success we're seeing and the rumblings of interest from other faith communities, we are now in the process of designing a toolkit, including a short documentary, pathways for engagement focused on recruiting for homes across the spectrum, resourcing and independent living, along with a package for faith leaders on the details on how they can call their people to action without creating a complex matrix for the faith community or the agencies that they're supporting. We've been very mindful of staffing capacities and existing priorities across faith communities and agencies, and it would be a downer to make things harder or create needs for more staffing on all of our ends. This conversation has gained traction at a larger scale, bringing the Anoka County pilot agencies to the table with Minnesota's DHS office, MinAdopt, the Greater Twin Cities YMCA, Aspire, and several others, resulting in a newly born initiative called the Connected Kids. Because of the interest in the simple approach, we found it necessary to create an online platform that organizes and supports the fractured efforts in the community's assets in a more collaborative and streamlined approach, county by county, so that the win stays at the local level. We'll launch this toolkit and online platform in Anoka County. We'll work out the bugs and offer it to any county that may benefit. Hennepin and Ramsey County Social Services have taken interest, and I've had to ask them to wait until we work out the kinks in Anoka County. Every county has an array of community problems, and every county has faith communities that can play a major role in literally begin addressing the systematic problems focused around the spectrum of child welfare through the recruiting of homes, resourcing, and independent living pathways. It would be our pleasure and desire to see hurting kids thrive because they have supportive relationships available to them.
All right, thank you, Ms. Welker, for your testimony this morning. Questions for the testifiers? Representative Moran.
Thank you, Mr. Chair. Just want to thank the presenter for her passion and care to recruit more foster parents. I was just wondering about the process. Would the grant go to your church to do outreach in Anoka County, or what is that process like?
Mr. Chair.
Mr. Peterson.
Mr. Chair, thank you, members of the committee. You know, the grant would come to the county agency, and as you could possibly hear through some of the testimony, there's a number of details that need to be worked out, and being able to use some of those dollars to assist us with that would be helpful. So the dollars would come to the county agency.
Representative Moran.
Thank you.
Any other questions for the testifiers? Seeing none, the committee thanks you for your testimony this morning. Are there any other people in the audience who wish to testify on House File 1130? All right, if you could please make your way down. Introduce yourself for the committee. Welcome to the committee, and state your testimony.
Good morning. Thank you, Chair Schumacher and committee members for allowing me to speak today. My name is Corey Vandenberg, and I'm from Oak Grove, Minnesota. My mother has done foster care for 18 years in Anoka County, and I have been a substitute foster care provider in her home many times. I help her to care for the children in our home while still living at home, because oftentimes these children can be very stressful to all of us involved. First off, I'd like to thank you all for everything you guys have done and continue to do to take care of these very vulnerable children in the state. There's certainly lots of problems with foster care, but we're moving in the right direction, and I thank you guys for everything you do. My concern today is House File 1130's appropriation of the $75,000 to Anoka County to establish and recruit foster care providers. We don't want any additional funds diverted to this provision that could be based on the basic rate for the care of children in the foster program currently. For your understanding, I just want to give you some facts on why this is worrisome. The current rate to take care of a child from 0 to 6 is $18.58 a day, $18.58 a day to take care of one of these children. A foster parent in any county in Minnesota must provide for the food, shelter, clothing, transportation, daycare, and any other needs of the child for less than $20 a day, while also supposedly making a tiny bit extra for yourself for the time. We need to put any available dollars onto the daily rate, in my opinion. This will increase the number of foster care providers in the state that can take care of these vulnerable children. All of the studies in the world and one-time incentives, because this is a one-time money, will not take care of the basic needs of children when the daily rate itself is so low. For your information, the USDA data shows it costs $38 a day to take care of a typical child in your regular home. And as I'm sure all of you know, most children in the foster care program, unfortunately, are not a typical child. Recruitment and retention of foster care providers is a statewide problem, not isolated to 1 or 2 counties. There needs to be an awareness of this plight for foster care providers across the entire state. They can't continue to subsidize the system anymore.
All right, thank you, Mr. Dannenberg, for your testimony this morning. Are there questions for Mr. Dannenberg? Seeing none, the committee thanks you for your testimony. Is there anyone else in the audience who wishes to testify on House File 1130? Seeing none, any final questions from members for the bill author? Final word, Representative West.
Thank you, Chair and members, and I hope you have a good morning.
Mr. Chair?
Representative McDonald.
Is this your first time in the committee here?
It is not Representative McDonald.
It is not?
No.
Okay. I was just wondering, these bags are here, plopped in front of me, so just wondering what I was supposed to do
Your
with that.
curiosity amazes us all. With that, I will renew my motion that House File 1130 be re-referred to the Committee on Health and Human Service Finance. All those in favor signify by saying aye. Aye. Opposed, same sign. The motion prevails, and House File 1130 is re-referred to the Committee on Health and Human Service Finance. Thank you, Representative West.
Thank you.
Next up, we have Representative Albright with House File 2115. As he's making his way forward, Representative Albright moves that House File 2115 be re-referred to the Committee on Health and Human Service Finance. We have the bill in front of us. Representative Albright, to your bill.
Good morning, Mr. Chair and members. Members, we know the quality of care provided in Minnesota is generally very good. We pride ourselves on it, and generally our providers are efficient as well. But as with anything in life, improvements can be made. Thankfully, steps have already been taken to identify the areas for further quality improvements, and we have providers in our state that have successfully taken steps to make such improvements in patient outcomes. It is from these efforts that the House File 2115 is derived to systematically adopt such reforms across Medicaid. First, in 2015, the Minnesota Department of Health issued a report to help identify areas for improvement. Using the Minnesota All Payers Claim Database and 2012 data for 4.3 million insured Minnesotans, the analysis found that Minnesotans experienced an estimated 1.3 million potentially avoidable health care events, accounting for nearly $1.9 billion, or 4.8% of total health care spending in the state that year. While not all of these events are actually avoidable, the report identified areas where we can look to take steps to improve and coordinate patient care and save costs. Potentially avoidable admissions, readmission, and emergency department visits. Secondly, our own hospitals in Minnesota have taken steps to look at rates of potentially avoidable hospital readmissions. They won the 2014 National Quality Forum Patient Safety and Quality Award for their reducing avoidable readmissions effectively. Over a 2-year period, the participating 82 Minnesota hospitals prevented over 5,400 potentially avoidable readmissions, helping patients stay out of the hospitals and save millions of dollars. This bill draws from what we have learned from both the Minnesota DOH report and the RARE campaign to help us reward value over volume and quality over quantity for our Minnesota Medicaid beneficiaries and taxpayers. And importantly, the bill seeks to do this without telling providers how to improve patient care. We just focus on and reward better patient outcomes, and let providers continue to do their great and innovative work to figure out how to achieve these important goals. Mr. Chair and members, with this I have a representative from 3M who is an expert on the particulars of the analysis and the metrics of this bill. And with that, I will turn over the testifier's table to him for further explanation of the bill itself. Mr. Chair, thank you.
All right, welcome to the committee. If you could please state your name for the record and present your testimony.
Thank you, Mr. Chair and members of the committee. My name is Chet Strorny. I am a consultant working with the 3M Health Information Systems State Initiatives Program and have many years of experience in government healthcare programs, including serving as CMS HICVA Regional Administrator for the Department of Health and Human Services in Chicago for many years. I work with state Medicaid agencies around the country who have adopted 3M tools and methodologies in their payment and performance management programs. I'm pleased to be here today to highlight examples of state Medicaid agencies who have moved from paying for volume to paying for value, improving outcomes, and reducing waste. You received a document which provides detailed information about key characteristics of successful state programs, how these programs work, including details of the steps a state takes when they adopt one of these programs. The key characteristics of successful outcomes measurement programs include: 1, focus on the most important and costly patient outcomes. These include potentially avoidable admissions, readmissions, ED visits, emergency room visits, and complications. And as Representative Albright noted, those were the key avoidable events that were studied through the Minnesota Department of Health. Identify and quantify potential healthcare waste. Effective outcome programs begin with a state's systematic identification of the hundreds of millions of dollars in waste in their Medicaid program, with a full-scale analysis of their claims database to identify potentially avoidable cases and the total potential excess expenditures associated with those cases. As Representative Albright noted, Minnesota has already taken a substantial step forward in analyzing and identifying waste throughout its healthcare systems. As he noted, the report that was done by the Minnesota Department of Health in 2015, it identified 1.3 million potentially preventable admissions, readmissions, and ED visits through the state's all-payer claims database, and accounting for approximately $1.9 billion in cost, which is 4.8% of the state's total healthcare spending. This important study can be updated to serve as a baseline for the outcomes-based, value-based payment models proposed in this bill. Outcomes programs are designed to support hospitals and health plans in two essential ways. These organizations receive fair, clinically credible, and transparent performance reports with actionable information. And two, it creates financial incentives that motivate hospitals and health plans to focus on avoidable events and to create interventions to reduce them. States that have successfully saved millions of dollars by eliminating waste and improving quality actively engage their Medicaid health plans and providers in the initiative. Key steps include: 1, target preventable events, track risk-adjusted provider performance compared to state norms, distribute reports to plans and providers with actionable information, and establish financial incentives with rewards and penalties to motivate plans and providers to reduce potentially avoidable events. Let me just cite a few examples I think there's several, 8 or 10 examples in the paper that we distributed. In Texas Medicaid passed a comprehensive Medicaid reform legislation in 2011 that mandated quality-based payment programs for hospitals and managed care plans designed to increase efficiency, improve outcomes, and reduce waste. These programs were fully implemented by 2014 and are now generating more than $90 million a year in direct sustainable savings by reducing avoidable admissions, readmissions, and ED visits in their managed care programs, and avoidable complications and readmissions in hospital services. The state of Maryland, starting in 2011, Maryland's All-Payer Health Services Cost Review Commission reduced preventable hospital-acquired complications by 20% statewide in the first 2 years of the program, generating $105 million in savings. By year 5, preventable complications have declined by 50%, generating over $180 million in savings. And the result is better patient outcomes. The results of these effective programs have been published in Health Affairs and the New England Journal of Medicine. And there are other examples that we list, and certainly I would just echo what Representative Albright said about the very innovative program here that the Minnesota Hospital Association implemented and for which they received the National Award for Patient Quality and Safety. We have estimates of savings based on what has happened with these other states. A conservative estimate of savings and outcomes, if a program like this is implemented in Minnesota, that the two programs for both managed care plans and hospitals could generate a combined $50 to $60 million savings annually by year 2 and $70 to $80 million annually by year 3. The cost of implementation would be $500,000 or less. Generally, states, when they implement programs like this, will hire a payment consultant to assist them in the process. Thank you very much.
Thank you, Mr. Strani, for your testimony this morning. Representative Dean.
Thank you, Mr. Chair. Mr. Strani, I just had a couple questions about your how you've implemented this in other places. Some of the things that we have tried to look at in the last couple of years have been about kind of easy things that hospitals can do to lower cost and to improve service. And just kind of like the bottom of the tree would be like never events, and then infection, so never events, wrong site surgery, foreign body, those kinds of things. Then the next level up would be hand washing, surgical equipment cleaning, those kinds of things, to doctors not wearing ties, to those kinds of things that are kind of easy on the bottom. And much of that is just repetition and rules that people, habits and rules that, you do that actually have big measurable results. And I can understand how when you try to get people to do good habits, it's really hard, but then once you do it, you can see some effects from that. So that I really understand how to change the culture in order to do that, to pull down infection and readmission. Some of that is easy, some of it's harder. Then the next level up would be measuring outcomes and procedures, and that's when it gets a little bit thornier for comparing hospitals to each other with different patient populations, and I would imagine that you get some pushback on that. And then the hardest part is when you attach payment models of rewards and punishments for those outcomes. You talk about just if there's a kind of a scale like that of how difficult things are to implement and what kinds of pushback that you might get from people trying to implement such a thing. Obviously, these are all great ideas, but as you move up that ladder, things get a little bit harder. So what have been some of the difficulties and the biggest challenges in other states in implementing such a plan?
Mr. Stroney.
Sure. It's some very good question and a very good overview of programs and what is being done here in Minnesota. The healthcare system is very complex in this country, and obviously when a state approaches a program like this, it's very, very, very important that there be transparency and education with the involved providers or health plans. Very open communication. That's why the process will take anywhere from 9 months to a year to implement something like this. Maryland, in the Maryland example where they implemented potentially preventable complications, had extensive meetings with their hospital community. Yes, there is resistance to change, and we see that. However, the value or the effectiveness of the programs that we have seen implemented is that if using the claims data from the providers, in other words, the providers do not have to submit additional information, or the encounter data from health plans. That data is risk adjusted. So you mentioned the different population among hospitals. Some hospitals have sicker patients. So the hospitals are compared on an apple-to-apples basis because the data is risk adjusted. And the information is shared with those hospitals. Ohio, who is implementing a program like this right now, of potentially preventable readmissions, sent reports, I think it was for 2 years, to their plans and hospitals before they implemented any payment adjustment, any financial incentives. So there was a period of time for providers to adjust to this, to look at the data, look at their own data, look at their own systems, and how they can improve. The goal here is for providers to improve. We see that in the states that we've been working with across the country. I hope that answers your question.
Chair Dean.
Yeah, Mr. Chair, and it kind of gets at some of the initial, obviously, resistance that you get at. And we were recently down at Mayo and just talked to them about how difficult it was to establish never events in their surgery department, and just about how basic that was, how they can get to 0 events in 10,000 surgeries by doing very repetitive procedures that were hard to implement. So it's really hard. It was hard for them to do, and never across 10 is easier than never across 10,000.
Right.
And they're able to do that by a lot of repetition. So there was a lot of resistance to that, but it it was kind of an eye-opener for me. But when you're looking at payment reform, that's a little bit of a different cat. And one of the things that we're trying to figure out is, I see in the bill you talk about preventable admission that we've struggled with in the past, particularly in Medicaid population where you have repetitive admissions. Do you look at avoidable days? So in other words, people who are in the hospital that maybe don't really need to be in the hospital to get them to a more appropriate level of care or out of the hospital entirely if they're there too long?
Mr. Stroney.
Sure. And again, very, very good question in terms of avoidable admissions. And in the Minnesota Department of Health study, this was examined, in great detail. And so, the way the system works, as we all know, is that if you have good care in the community, primary care physician for the individual, a care management plan, if many of these Medicaid recipients will be high-cost, high-risk individuals because they have multiple chronic diseases, they have behavioral health issues. So it's a population that has to be managed by a primary care physician. So that's where the care, and if a managed care plan is responsible for that population, the incentive here is that if they manage that population very well and have effective care treatment plans, care management plans, they will keep that patient out of the hospital. Not all admissions are preventable. We're not saying that. Not all admissions are, readmissions are preventable. However, the incentives are built into these programs so that providers can look at the data and then ensure they have the correct programs in place to manage that population, whether it's a hospital or a managed care plan.
Chair Dean.
Thank you, Mr. Chair, and I really appreciate it. I like this bill a lot, the direction that it's going, but obviously when you measure value and you pay for value, how you measure that is everything. And who has skin in the game and who gets the incentives is really what we have to, I think, be very careful of when we are going down this path. But I do thank you.
You're welcome.
Representative Murphy.
Thanks, Mr. Chair. And so I just have a couple of questions as well. This is not a new concept for the legislature over time. And it is something that we've talked about and embedded. So as I'm trying to read through this again and through the information that you provided this morning, can you help me understand what we're adding that is new conceptually or in law that would change what's currently happening and what would be different?
Representative Albright.
Mr. Chair and Representative Murphy, I think that what we've found, and to the great credit of homegrown 3M, is a collaboration between the systems already in place. Data is everything, and I think as I've discussed this with the testifier as well as with the representatives from 3M, it's about mining the data and having fresh eyes on it. And I think that facilitates a kind of a reawakening to, as Chair Dean said, how do we prevent those never events, or to look at patient loads, whether they be high risk or not at high risk, to identify measurable outcomes that might be more beneficial in terms of less days, fewer overnights in beds, or reoccurring visits to either the primary care or the specialist, particularly when you have multiple situations or multiple occurrences, whether it be diabetes or hypertension, that type of thing. So what we're trying to do is bring a collaboration and a more comprehensive look. This is not to X anyone out from the conversation, and in quite the opposite. I think it actually encourages a greater collaboration from all the stakeholders.
Representative Murphy.
Thank you, Mr. Chair, and I appreciate that. And I think conceptually I appreciate what's being proposed, and I'm just trying to understand, or maybe one of you can walk me through like who does what to get to that goal, because there are a lot of players. We already have law in Minnesota, we have a law. I think the department already has some of this authority. Maybe we need to have the department come down and talk about that a little bit. But what is the role of a vendor? What is the role of the department? What is the role of the managed care organization, the hospital? Who sees the data? How does it get mined? I just need to understand sort of the linear, how does this work?
Sure. And I would just add, very good question. A typical program like this is the state Medicaid agency receives the data. They have all of the hospital discharge data. You've got an all payer claims database here in Minnesota. You also receive, the state's required to submit what they call encounter data. This is a bill that would normally be submitted if you run a fee-for-service system to the state that identifies the diagnosis and what treatment the person receives. So all of that data is received by the state. The data is then, in a program like this, would be through these software systems. You would run that data through the system, and the state already licenses these tools from 3M, the potentially preventable event tools, or other tools that the state might decide to use. It's not limited to 3M. And then reports are generated. You know, I'm oversimplifying it, but reports are generated on hospital ABC or hospital or managed care plan X. And those reports are submitted to those providers or the managed care plans, and it shows how well they are performing compared to their peers. And it will identify whether it's readmissions, ED visits, admissions. It will have actionable data that they can look at and analyze. They can actually drill down to the patient level, to the doctor, and examine the practices. Why are we different for the same procedures compared to other peer health plans or hospitals? So the key is giving much better data that a provider can act on. Today, and this is true of the U.S. healthcare system, we have what we call process measures. Typical HEDIS measures. It measures a certain conditions that a patient has. HEDIS measures are good, but what we're seeing across the country, and studies that have shown this, the movement is a way to measuring outcomes. Let the doctor do what the doctor does best and measure that outcome against peers and statewide norms.
Mr. Chair.
Representative Murphy.
Thank you. That's helpful for me. And I'm just wondering, Mr. Chair, if we would have time for somebody from the Department of Human Services to join this conversation. I just want to understand what we're doing today and what this would add in terms of outcome evaluation.
Absolutely. If someone from the department would please make their way down. Oh, we've got a couple of them today, Representative Murphy.
It's a big question. And they look so excited.
Welcome back to the committee. If you could please state your name for the record and present your testimony.
Thank you, Mr. Chair. My name is Julie Marquardt. I'm with DHS. I believe the question is what does this do, or what are we currently doing that this would impact or not impact?
Mr. Chair.
Correct?
Representative Murphy.
Thank you, Mr. Chair, and thank you, Ms. Marquardt. I am curious to know from the department's perspective, what is, you don't need to do an exhaustive review of the law, but what do we have in place already that is furthering this goal? And what is missing that we would want to consider as we're listening to Representative Albright's bill?
Ms. Marquardt.
Thank you, Mr. Chair. So we have several initiatives right now that are in place that I think we would need to address if we were to implement something a little bit different. So we have withholds on the managed care organizations that address these three areas of emergency department use, admissions, readmissions. Those are in law right now, and we hold the managed care organizations financially accountable for those. That's done on an annual basis. We also have the integrated health partnerships, which is 21 organizations, nearing around 400,000 enrollees are attributed to these organizations, they also, as part of their quality measures, are measuring those 3 areas, and those are a component of whether they're eligible to get the full amount of their shared savings or are eligible to get their shared savings. So they aren't using the exact PPE method that is described in this particular bill, but they are using measures that are similar to. And I think one of the things that we have looked at, we did used to have, we just sunset about 2 years ago, related to the RARE campaign that was mentioned, we used to also have a 10% rateable reduction in payments to hospitals in an effort to get them to improve their readmission rate. And when that was accomplished, we actually sunset that about 2 years ago. And that applied to fee-for-service only. But I think one of the things, no matter which product you use, one of the difficult things is for providers to understand what parts of it, what were the steps they need to take to prevent the action. A lot of these are proprietary software, and so you can't necessarily understand why my patient flagged here, but their patient didn't flag there, and what is it that caused it to flag within the software. And so in order for providers to take the steps or institutionalize those steps, they need to probably have a little bit more deep understanding of the software itself and how it's flagging. The other thing is when you're holding financially accountable, the IHPs do it through a total cost of care, where we look at all of the costs for all of the care. But if you're doing it not within that arrangement, then it's difficult because sometimes the preventable action really isn't the hospital itself. It's something that happened outside of the hospital. It's something that should have happened in the outpatient setting, at a clinic, at a mental health facility, and you can't really hold, it's difficult to hold a hospital financially accountable for something that they don't have control over. So it's outside of a total cost of care model, it becomes more challenging to figure out who is the financially responsible entity. And then if something goes wrong, sometimes patients don't want wherever happened wrong to correct it. So now the costs that we're actually bearing are with another provider. But we can't necessarily hold them accountable because they didn't make the error in the first place. So it is a complicated system that I think the IHPs probably do the best job of looking at the total cost of care, and regardless of where that happens, they're accountable for it, they understand, they have a contract with us. But again, I don't think just simply changing the software is going to change the outcome. They actually are using and working with 3M on how to better give data and information to the IHPs, and whether or not that turns into some use with financial accountability, I think that's to be seen. But we're certainly open to looking at better ways to measure quality, to look for opportunities for providers or our managed care organizations to have more actionable steps that they can take to prevent things. But I do think there's some duplication here that this bill introduces, and I'm not sure that it's a value-added duplication at this point.
Representative Murphy.
Thanks, Mr. Chair, and I appreciate that feedback from the Department of Human Services, and we could probably spend a lot of time, maybe all of the rest of our 8:15 meetings, our 8:15 a.m. meetings could be just spent on this, and we could write a dissertation or something. But one of the things that I think is most difficult about this, Representative Albright, is the idea that we would do this analysis in the department. I think it would happen in the department. And then it's got to be translated through various vendors and contracts, from the Department to the health plans, and then from the health plans out to the networks of providers. And what we want to do, I think, is change the behavior of the providers themselves, whether it's the hospitals or the doctors or the nurses, et cetera. I think that's one of the tricks we've got to figure out. And, I'm interested in this. I'm interested in figuring out how to make this work, or how to achieve the goal that I think is embedded in your piece of legislation. But I worry about the translation of the data that we might generate at using a vendor and new software, and what that would actually mean for care provision.
Are there any other questions for the testifier? Is there anyone else who wishes to testify on House File 2115? If you could please make your way down. Welcome to the committee. If you could please state your name for the record and present your testimony.
Thank you, Mr. Chair. I'm Mark Sonneborn. I'm Vice President of Health Information and Analytics for the Minnesota Hospital Association. And I am speaking on behalf of our 142 hospitals and health systems we represent. We are opposed to this bill. As has been alluded to, there is already a quality reporting and incentive system in place in Minnesota for hospitals known as the Statewide Quality Reporting and Measurement System, or SQUIRMS. SQUIRMS has evolved over the years to align with federal reporting requirements to the Centers for Medicaid and Medicare Services, CMS. The CMS and SQUIRMS measures already include measures for readmissions and for complications. The measures described in this bill do not align with what is currently reported through either the federal government or SQUIRMS, so this would be a significant burden and confusion to hospitals as well as patients. The burden would be more on the analytics and quality improvement side than the collection side, so that the data burden is not as much. We have other concerns as well. This is based on Medicaid only. Many hospitals don't have sufficient Medicaid volume in order for the state to do a statistically reliable analysis of their performance. In fact, our own data show that 74% of Minnesota hospitals, that's over 100 of them, have less than 10 preventable readmissions for Medicaid in a year. There are simply not enough cases for most hospitals to make this a fair measure for an incentive program. We're also concerned, as been previously mentioned, that the language in this bill is vendor-driven. Likely outcome of its passage would be that hospitals have to purchase proprietary software to analyze their data. And I'd be happy to answer any questions.
Are there any questions for Mr. Sonneborn? Seeing none, the committee thanks you for your testimony this morning. Is there anyone else who wishes to testify on House File 2115? Seeing none, final questions for the bill author. Final word, Representative Albright.
Mr. Chair, and I think I will leave you with this. When you consider the fact that MA spend in this state is growing at a rate of about $2 billion per biennium, the testimony suggests that there are disparities in terms of the hospitals that do or do not have MA patient load. But when you consider the fact that our state budget and what we expend on behalf of our MA population, I think it's incumbent upon us to look and review very seriously every tool that comes our way to consider how we manage that caseload as effectively as possible. And in an era where big data is everything, and it is growing by volumes on a daily basis, I think it also becomes imperative for us to look at every tool, whether it is from a vendor, from internal to one of our agencies, to consider how we might be able to manage that caseload in a more effective manner. With that, I urge your consideration as we move this bill forward. Thank you.
With that, Representative Albright renews his motion that House File 2115 be referred to the Committee on Health and Human Service Finance. All those in favor signify by saying aye. Aye. Opposed, same sign. The motion prevails, and House File 2115 is referred to the Committee on Health and Human Service Finance. Thank you, Representative Albright. Next up, we're going to bring up House File 1453. And Representative Hamilton is not here, but I understand that Representative Flanagan is willing to present the bill since she is a co-author, and so Representative Flanagan moves that House File 1453 be re-referred to the Committee of Health and Human Service Finance. We also have the DE1 amendment that I believe was the agreed language that we wanted to bring forward on this. And so are there any questions to the DE1 amendment to get the bill into the form in which the newly crowned author would like to present it? Seeing none, all those in favor of the DE1 amendment signify by saying aye. Aye. Opposed, same sign. The DE1 amendment is adopted. Representative Flanagan, to your bill.
Thank you, Mr. Chair and committee. I And pinch hitting today for Representative Hamilton on the Minnesota Family Investment Program Income Exclusions bill. And essentially, this bill change is intended to not discourage marriage for folks who are on the Minnesota Family Investment Program. And I'm going to just turn it over to Ann Krisnick, who's the Executive Director of the Joint Religious Legislative Coalition.
Welcome to the committee. If you could please state your name for the record and present your testimony.
I'm Ann Krisnick, the Executive Director of the Joint Religious Legislative Coalition, which is made up of the Minnesota Catholic Conference, the Minnesota Council of Churches, the Islamic Center of Minnesota, and the Jewish Community Relations Council. So thank you for hearing the bill, and thank you to the co-authors. We have several that are here in the committee. As we went around the state talking with folks about various challenges that Minnesota families face, we heard about not only the need for an increase in the MFIP funding, but specifically from a number of faith leaders about people saying they had parishioners who said they'd really like to get married, but they couldn't afford to get married. And when we asked about that, just an example, if I'm a single parent with 2 children, so I'm a family of 3, I'm eligible for some MFIP contribution as long as my income is below $20,160. I may have met someone that I'd really like to get married to, but with a family of 4, the income cap would be $24,300. And in many cases, when the couple sat down and really looked at what their finances would be like, it made more sense financially for them not to be married. The faith community believes really strongly that if there are solid relationships, it's good for children to be raised in a 2-parent family if that's a healthy relationship, and we wanted to remove any disincentives. So I want to be really clear, the bill doesn't give you a bonus if you get married. It's not an enticement to get married. It's just to help remove the marriage disincentive. So for a period of 18 months, the new spouse's income would not be included. In your packet, you should have a document from the JRLC that goes through the various questions and answers about the bill. You should also have a letter from a pastor in Mankato, kind of talking about in his practice and when he's out that he hears people talk about the desire to get married, but the very real financial impact of that. And the Minnesota Family Council just submitted a letter this morning that you should have as well. The amendment is designed to have a cap on this benefit. So if I marry someone who is making $300,000 a year, I don't need the MFIP contribution. So the cap is set at 275% of the federal poverty guidelines, which is the measure that's used to determine if pregnant women and children over 2 are eligible for Medicaid. So that's an existing figure. That's where that came from. And then the amendments that you have in front of you also include some technical issues from the department. But our goal is to really allow families to get married if that's what they choose to do, instead of removing a disincentive that currently is built into the system for those families.
All right, thank you, Ms. Krisnick, for your testimony this morning. Are there any questions for the testifier? Representative Moran.
Thank you. Thank you, Mr. Chair. First, I just want to thank Representative Hamilton and Representative Flanagan for bringing this bill forward, and more importantly for JRLC for seeing the need to really elevate this issue. We know that the threshold to receive MFIP is so deep into poverty that families are making real decisions when they're not making enough wages livable wages to take care of themselves and their family, but have made the decision to have children. And I think we want to encourage, 2-household families. We want to encourage marriage. And this is a pathway to allow that to happen. And so I think it's a really, really good bill, and hope that this body can find a will in the dollars to support this. It's a policy bill. I mean, really, really cut dry. I think, on both sides of the aisle that we can see value in marriage in creating that pathway. So are you able to share any personal stories from individuals who have talked about really the impact of being on MFIP and really wanting to be and really wanting to have an opportunity to marry but don't?
If you look at the letter that's included in the packet from
Prisnack.
Pastor Vance Becker, who's pastor at a Missouri Synod Lutheran Church in North Mankato, he talks about the families that he works with, and I'm just going to read one paragraph from that. And he talks about the low-income families that he worked with in his church, those that attend the preschool at his parish. But in the fourth paragraph, I've worked with several couples who would like to be married but were not because they would have lost benefits that their families needed to meet their basic needs. These aren't families wanting state benefits to pay for luxuries. They're using the funds for things like food, rent, and gas money to get to work. These single parents are struggling to care for children while trying to transition to full-time work or going to school in order to be more employable. And this is what we heard from our faith leaders over and over again. So that I want to be really clear, the bill doesn't create an incentive for people to get married. It doesn't create a situation where someone would stay in an abusive or unhealthy relationship because there was some monetary benefit to that. It simply allows those couples that want to build a stable family for their children but are really struggling to have an 18-month period of time where that new spouse's income wouldn't be included. And one thing that we heard about frequently is a time when people are looking at getting married is often if I'm expecting a child, but that's a time when I'm going to be out of work because I'm about to have a baby and I'm going to have new infant expenses. So the 18 months was really designed to give the family time that that new child may be born and may be out of work for a while, but it gives the family a decent safety net to really get their finances in order and move forward.
Representative Moran.
Thank you, Mr. Chair. I just think it's really good common sense legislation, really, and just really create a pathway for families in poverty to be in a two-family relationship. So, again, thank you for bringing this forward.
Representative, thank you.
Any other questions for the testifier? Seeing none, the committee thanks you for your testimony this morning. Is there anyone else who wishes to testify on House File 1453? Seeing none, final questions from members for the revised bill author? Seeing none, final word, Representative Flanagan.
This is a good bill, and I hope you support it.
With that, Representative Flanagan renews her motion that House File 1453 as amended be referred to the Committee on Health and Human Service Finance. All those in favor signify by saying aye. Aye. Opposed, same sign. The motion prevails and House File 1453 as amended is referred to the Committee on Health and Human Service Finance. Thank you, Representative Flanagan, for stepping in today for us. All right, finally on the agenda today is Representative Smith with House File 1502. And as he makes his way forward, I'll move that House File 1502 be referred to the Committee on Environment and Natural Resources. Representative Smith, we have the bill in front of us. To your bill.
Mr. Chair, members, thank you. I do have an amendment that I would like to offer, Mr. Chair.
All right, I will move the A17 amendment. Representative Smith, to your amendment.
Mr. Chair, there are some technical changes. It deletes in the entire section 1, which is the posting of the signs. And furthermore, it changes the reporting date from 2019 to 2020 to give the department the appropriate amount of time to analyze the study.
Are there any questions to the amendment, Ms. Clarkfist?
Mr. Chair and members, with the A17-0225 amendment, we should also, on page 2, line 4, delete and section 488.57. If section 1 is removed, we don't need to have the definitions apply to section 1.
Okay, I will make an oral amendment to the amendment to do that. Could you please state that again, Representative Ms. Clarkfist?
Page 2, line 4, delete and section 488.57.
Are there any questions to the oral amendment to the amendment? Seeing none, all those in favor signify by saying aye. Aye. Opposed, same sign. The oral amendment is adopted. Are there any other questions to the A17 amendment? Seeing none, all those in favor signify by saying aye. Aye. Opposed, same sign. The A17 amendment is adopted. Representative Smith, we have the bill in front of us. The way you wish to present it, please present your bill.
Great. Thank you, Mr. Chair, for hearing this bill, and thank you to the co-authors on this committee, Representative Pierson and Representative Lomer. Mr. Chair, members, this bill deals with a 2-year moratorium on a product that is causing some health concerns, and I would like to have my first witness testify, please.
All right, welcome to the committee. Please state your name for the record and present your testimony.
Yeah, thank you. Good morning, Chair and committee members. I'm Jenna Grove. I'm the Legislative Program Coordinator at Clean Water Action and Healthy Legacy. I would also like to thank Representative Smith and some of our co-authors for bringing this bill forward. The legislation in front of you materialized because of growing concern from parents, community members, and public health professionals. In the mid-90s, the EPA, in an initiative to address growing stockpiles of waste tire, encouraged the use of shredded tire as ground cover on playgrounds and as infill on athletic turf fields. While good intentioned to address prevalent material in the waste stream that it has serious known environmental concerns, it probably wasn't the best idea to recycle it in a way that exposes children to potentially harmful chemicals. With that being said, there are two main concerns, and the first is that there have been studies conducted, although very limited, but from those we do have quite a list of chemicals that have been detected in the material. Many of them are already known to be hazardous to human health, and many of them also on the list have no data or testing for human health effects, making it a big question mark. And the other concern is just a general lack of scientific consensus on whether or not this is harmful to children specifically who could potentially cause these human health effects. And some say that it's fine because the level of concentration of the chemicals in the material are low enough. But it's most agree that there needs to be more study. And there are two studies currently being conducted. One, a federal multi-agency initiative between the EPA, the Consumer Product Safety Commission, and the Centers for Disease Control. And there's also a $3 million study being conducted by the state of California as well. And they are studying a variety of aspects, a couple of routes of exposure, measurements for duration of time spent around the material, and then also characterization of the components of the material under different conditions. So with that said, yes, a ban would be premature, but a moratorium just for 2 years until we can analyze those findings and have a clearer picture on how to proceed is just a cautious and responsible way, especially when it comes to our kids. Because in addition to the health concerns, there's also a cost aspect to consider. If the findings were to come back and say this was not a good idea, we need to take this out, how much it costs to do remediation for existing fields and playgrounds comes with a very serious price tag. And having to do that across the state would be pretty daunting. So I know that there are other people that want to testify. I'm more than happy to answer any questions.
All right, thank you, Ms. Grove, for your testimony. Are there any questions for the testifier? Representative Flanagan.
Thank you, Mr. Chair. Ms. Grove, can you speak to just how expensive that would be?
Ms. Grove.
It differs between playground and field, and I know that one of our other testifiers might be able to answer that question because they're actually doing remediation in Duluth.
Representative Flanagan.
Thank you, Mr. Chair. That's it.
All right, any other questions for the testifier? Seeing none, the committee thanks you for your testimony this morning. Next, we have Mr. Kersling. Welcome to the committee. If you could please state your name for the record and present your testimony.
My name is Corey Kersling, and I'm here representing Duluth Parents for Healthy Playgrounds. Good morning, everyone. I'm an industrial maintenance engineer in Duluth. I'm a parent of a very active 9-year-old boy. His name is Jack Henry Kersling. I want to impress upon you that I am not what you would call a helicopter parent, which has been labeled since this has started, always hovering and constantly worrying about his safety or his health. In fact, on a personal note, my son is actually, by the time he's 10 years old, he'll be a black belt in martial arts. So that's, I want to, we'll get to the point here, and I'm here to share my experience along with what I have witnessed. This started when my son was in first grade at Lester Park School in Duluth. We had noticed the tire mulch on his school and thought what a good way to recycle tires, and it's a soft surface. Over a bit of time, we discovered the mulch on his clothes all over our house, constantly cleaning them up from the washer and dryer out of clothing pockets. His clothes became stained black from the material. We would find the dust from the tire mulch on his skin, staining him as well. This continued for that first year. He then attended a summer daycare program held at the school. The hotter weather and increased playing duration led to more concerning side effects. We could smell the material on him, and we would scrub it off of his skin every day. He complained of headaches and sore throats. On windy days, he described the black dust as black tornadoes that would swirl all over the playground. The final straw was the realization that he was blowing it from his nose and therefore breathing it in. The thought of, what is this exactly? Is it really safe to be playing on? Fueled a personal need for my explanation and health research. My wife and I explained to him that until we understood the product more and that it's safe, we requested that he avoid playing on it. Although we were concerned that this would alienate him from his friends in regular play, we strongly encouraged him to try his best, and he did. It didn't take long to discover other parents with the same concerns and communities moving to replace the product. We found a different, we went to the extent of avoiding certain sports that use a crumb-like product. We started playing soccer, and before his practice or game, we asked if all the fields are grass, and they were. So we encourage the sport for now, but we have concerns about the future exposure as the surfacing changes. Every night for months, reading study after study what harmful effects could amount to, what other natural products could meet the safety standards, and with the involvement of other family members and equally alarmed parents, we were able to raise money for a local toxicity test. The collective effects of the test and assessments are available if you'd like to see it. I personally have witnessed young children roll in the tire mulch, bury each other in it, stuff it in their clothes, put it in their mouths. Their interactions with the materials are intense and repeated day after day. Jack now currently is in third grade. I've learned more about playground safety and surfacing or tire manufacturing than I ever thought I would care to. I've connected and formed groups with concerned parents from literally all over the world. Our local collective efforts have resulted in the upcoming replacement of the tire mulch across the Duluth Public School playgrounds. It's a huge achievement for our own community, but I want to make clear about the common sense of what brought me to this. There's so many different studies out there that show different things, from negative to positive, that, and it's just all over the board. So what I came to is what I use in my work as a maintenance engineer. What are the signs that I see? I can smell it. It's off-gassing. I can see the dust, and it's coming from my child's nose. It's breaking down, and he's ingesting it. The temperature readings I've personally taken off the tire mulch is as high as 150 degrees. All these things lead me to believe that this is not okay for children to be exposed to. This has led me here today. I'm not fond of public speaking, and I'm not a huge environmentalist. I'm not a doctor or a scientist. I'm a parent and a maintenance engineer. And as such, I know there are always alternatives for healthier improvements. I ask you to please go to these playgrounds and athletic fields. Feel the heat, smell the material, see the material on them, and help make a change. I'll also mention that currently with the removal and cost of the removal, and we've gotten numbers in Duluth, those numbers for 10 playgrounds were $670,000 for removal and replacement. We're doing fundraising of our own to help out the school district to help do exactly that. I know any help for cleanup would go a long way for Duluth or any surrounding communities. Thank you for your time.
All right, thank you, Mr. Kersling, for your testimony this morning. Are there any questions for the testifier? Seeing none, Dr. Abraham, if you could please make your way forward. Welcome to the committee. If you could please state your name for the record and present your testimony.
Thanks so much, Mr. Chair and members of the committee. I'm Dr. John Abraham, and I'm a professor of thermal sciences at the University of St. Thomas. And why would I be coming down here to testify on this issue? My area of study and my areas of expertise is on temperatures and their effect on the human body. And I do work, both academic work, but also consulting work for industry. So I want to make a few points. I'm not going to take very long. in my in my discussion about this, but this artificial turf that we're talking about gets very hot. And the reason why it gets hot, there's a number of reasons. First of all, it's very dark. It's great at absorbing solar energy. It's like in the summer, if you're walking around outside without shoes on, and then you step from the grass onto a street, an asphalt street, it feels hot because it is hot, because the dark colors absorb sunlight. So we know it gets hot. And in fact, the measurements show that it's getting hot, but we've got a double whammy here. What typically keeps areas cooler is they're able to respirate, they're able to give off water to the air, and that can keep temperatures down. This artificial stuff can't do that, so you really have two factors happening. And temperatures can get up to about 185 degrees. Now, to put that in perspective, those are temperatures that will cause what's called a deep partial thickness burn in adults in 6 seconds. A deep partial thickness burns in children in 4 seconds. Deep partial thickness burns, those are bad second-degree burns, can require medical attention or skin grafting. We're not talking about it's warm and uncomfortable. We're talking about it's hot enough to cause skin burns. So that's one of the issues. The other issue is there are systematic risks to humans when they're exposed to these kind of temperatures. Not just the fact you may be burnt, but your whole body has to react in a way that is dangerous. You can become dehydrated. You can experience heat exhaustion, heat stroke, cardiovascular stress, and respiratory problems. Who's at risk of this? Certain groups, such as kids and elderly. Their bodies are not as efficient at getting rid of heat in a hot environment, especially for people who are exerting themselves, let's say in a playground or a sports field. People with respiratory problems and people with heart problems, whether you've got clogged arteries or weakened heart, those people are less able to manage the heat stress. So I just wanted to come in and say a few words about how my profession views this. I'm not making a value judgment on what kind of fields are better. What I'm here to do is to tell you that the evidence is clear and convincing in the scientific community that these temperatures on these fields can reach unsafe levels. And those are all the comments that I have.
All right, thank you, Dr. Abraham, for your testimony this morning. Are there any questions for the testifier? Mr. Inus, please make your way forward. And please state your name for the record and present your testimony.
Chairman, members of the committee, my name is Ward Inus here on behalf of Liberty Tire. Liberty Tire is the largest tire recycler in the country with a significant operation in Savage, Minnesota that recycles approximately 8 million tires per year. The legislation under consideration is misguided and not supported by the science. Put simply, crumb rubber fields and playgrounds are safe to play on. There's a robust body of scientific literature that includes dozens of studies, peer-reviewed academic analysis, and government reports that clearly indicate that recycled rubber is no more dangerous than surrounding soils or other products that are part of our daily lives. In recent months, 2 additional studies have emerged that reaffirm that synthetic fields are safe to play on. In December of 2016, the Dutch National Institute of Public Health and Environment published a report that concluded there is no heightened health risk associated with recreating on synthetic turf fields. Even more recently, the Washington State Health Department released the findings of an investigation, a cancer cluster investigation, that concluded that there is no elevated risk of cancer among soccer players who play on synthetic turf. Now, I think this investigation was important because one of the reasons why this issue has come to the forefront is that there was a Washington State soccer cup cancer cluster that was widely discussed in the public media. This was simply a soccer coach up from the University of Washington who had a couple players who got cancer, started making a laundry list of players, other soccer players who had acquired cancer of some sort. And this cancer cluster kind of was elevated in the public mind that there's some kind of correlation between synthetic field soccer players and the incidence of cancer. Well, the University of Washington, in conjunction with the Washington State Health Department, decided to do an investigation and really determine once and for all, is there any correlation? Is there any cancer cluster that's out there? And they came back and they concluded not only was there not a cancer cluster, a correlation between soccer players and cancer, there was actually a lower incidence of cancer among the soccer players and the general public in the state of Washington. So I think they debunked one of the kind of leading urban myths that was out there regarding the health risks associated with synthetic turf. It's also worth noting that there are tangible benefits to deploying artificial turf fields. Artificial turf fields increase play times by a factor of 4 or 5, thereby dramatically enhancing recreational opportunities for the public. In addition, one artificial turf field will typically save 100,000 gallons of water over its life cycle, while recycling approximately 20,000 tires. Finally, no other state has adopted the statewide moratorium or the signage requirement that's been pulled out of the bill. This is really premature. I mean, science is an evolving, it's a constant, endeavor, and we continue to examine the science, update the science, do more studies, fill the information gaps that are available. But based on what we know today, and I think that's what public policymakers should consider, based on the best science available today, crumb rubber fields pose no enhanced risk, unacceptable risk to people who recreate on them. I don't have any credentials as a toxologist or chemical engineer or anything like that, but one of your former colleagues did, Representative Barbara Russo, PhD in chemical engineering. And when this bill was offered as an amendment on the floor, she was one of the first people to get up on the floor to oppose the amendment. And I'll paraphrase what she said. She said, "This amendment is premature and unsupported by the science." I believe the amendment was summarily withdrawn and a vote was not taken. But there was somebody within the body who had the credentials, who had the background in science to speak authoritatively about what's before the committee today. And I think if she was here today, she would probably make the same comments. Thank you, Chairman. That's all
All right, thank you, Mr. Ines. And could you once again just give the sources for the statistics and the studies that you were referencing there?
I can give you a bibliography. I mean, what do you mean?
A bibliography, really?
Oh,
yeah, if you could.
From Washington.
Oh.
Just in your testimony, you had cited a couple of recent studies. What were the sources for those again?
Yeah, the recent studies was the University of Washington, in conjunction with the Washington Health Department, released one about this cancer cluster investigation, try to refute the idea there's a cancer cluster and some correlation between soccer players and playing on artificial turf. The other one came out of the Dutch National Institute for Public Health and Environment and was published in December of last year. And that one also concluded that they deemed it safe, there's no unacceptable enhanced risk to recreate on synthetic turf fields. And in the Netherlands, I think synthetic turf is very predominant. It's a very common surface, especially in those climates like Minnesota where the seasons are short. The synthetic turf fields can elongate the season. You can play early spring, late fall. There's been testimony from the Minneapolis Public Parks Board that is probably about a 4 to 5 to 1 ratio. And it's especially important in those urban environments where property is at a premium and usage is very high. So in those urban environments, this artificial turf is really useful. It gives people more recreation opportunities, more public health opportunities. The park board testified that they'd have to shut down the grass fields. They just couldn't take the usage in those urban environments. And so a lot of the neighbors and the communities were actually advocating to put crumb rubber in to enhance their opportunities to recreate on it. So we can talk about the potential risks that are out there, but there are also very tangible, real benefits that there's no question about. And that's what I'm here to articulate.
All right, we have a few questions for you, Mr. Ines. Representative Allen.
Thank you, Mr. Chair. And if we waited for conclusive evidence on something in any determination, we would not make any decisions, because if there's any ambiguity, then we can argue both sides, and there are studies, but problem is oftentimes we don't have sufficient funding to develop studies or to so that there becomes wide consensus. And oftentimes we don't have time, and so so we need to weigh the benefits and the risk, and so not persuaded by the benefits of when it comes to the health of children and vulnerable adults. And so we can make determinations more likely than not probable. We should err on the side of caution. And so I think that's why this bill is moving towards warnings and not just either as one colleague suggested, put money towards funding to study it or grants to clean it up. And that's really the issue, is that that there are parents that are in town halls that they've been talking about this issue for a few years and very emotional, worried about their kids. And so I think it's time to, like, to get rid of it. And so, I went to dinner at Egan, and I don't, get to the suburbs very often, but and we went for a little walk after. It was in the summer, and there was a park in Egan, and there was nobody there, but I was just like amazed. It was a park that it did not have this black rubber stuff on the ground. It had like some kind of high impact cushioning or materials. Maybe it was cork or something for the children if they fell off. And then there was speakers. It was all fenced off. There were speakers, and they were pumping in classical music. And I was like, and then I drive down, like, especially in like Karen Clark's neighborhood in Phillips, and it's busy streets, no fencing, and this type of material, and it's mostly children of color. And so, we don't have to bring up every time about, environmental racism, but this is, to me, it's a classic example. But it doesn't get anywhere when we present it at that issue. So I'm glad that this is being brought now, and that, that there's some bipartisan support to address this issue. Thank you.
Thank you, Representative Allen. Any response, Mr. Ines?
Chairman, Representative Allen, your points are well taken. I think what we have here, though, is almost a 2-year moratorium on any local government, any jurisdiction putting in a crumb rubber field. And I think a lot of communities that do their due diligence, they want what's best for their citizens, what's best for their children. Edina recently had a very thorough vetting of whether crumb rubber is appropriate for their community. They made the decision, an informed decision, I would argue. They fully vetted it, and they decided they thought that was the best decision for their community. I think, especially when the science not only is unsettled, but currently is in favor of the safety of crumb rubber, I think it's very heavy-handed for the state to come in and impose a statewide moratorium that no other state has imposed, and basically say no local government can make a decision about what they view as best for their community. And that's what this bill does.
Representative Murphy.
Thank you, Mr. Chair. And Mr. Ines, thanks for coming and sharing your perspective. And I don't know a lot about the work that Liberty does, but can you share with us just a little bit about other uses for recycled rubber tires besides the one that we're describing today?
Mr. Ines.
Yeah, Chairman, Representative Murphy. The crumb rubber is one of the most predominant uses. And as you can see, one crumb rubber field takes 20,000 tires out of our landfills and et cetera. There's some energy uses for crumb rubber that are still, I think, fairly in embryonic stages, but that's something. But there aren't a lot of uses for it. I mean, if you go out to the facility in Savage, they process 8 million tires through that. And you can see the stacks and stacks of crumb rubber that's going to be shipped out of there into the other facilities. I think the EPA, to their credit, I think, did encourage the Liberty Tires of the world and stuff to go in that direction. At that time, the science was probably less definitive than it is today. It's a little more definitive. There's more studies. There's actually a pretty robust, as I said, body of literature out there. I think we welcome what's going to be coming down in 2019, 2012, this more comprehensive study that's going to fill some of the gaps. And we welcome that, and we've been participating in that to make sure the methodology is sound, make sure they're testing the right sort of fields. So we certainly welcome the scientific literature to expand and grow. Scientific inquiry is not a static endeavor. It's constant, and if we use the litmus test, if the litmus test was, well, until we have absolute 100% definitive proof that something's safe, we're not going to do anything. There'd be a laundry list of things that we wouldn't be touching or walking on, or, based on the testimony from the scientists, maybe we should ban playing on black asphalt, because that gets extremely hot. There's all kinds of things. So I just think we welcome greater scientific inquiry. The study that's going to come out in 2020, I think, will tell us a lot, Representative. But I think it's really premature to adopt this kind of policy on a statewide basis based on what we know today.
And Mr. Chair.
Representative Murphy.
Thank you, Mr. Chair. Mr. Ines, are you a secret science nerd that we just didn't know about that about you?
Chairman,
I am.
I am not a science nerd. I'm so far out of my element right now. It's
Mr. Chair.
But the only thing I will say this, I'm not a toxologist, I'm not a scientist, I'm not a chemical engineer, but I believe in science, and I can read. And so, I mean, I think, that's, if you take the time to read the scientific literature, the executive summaries, you can get a pretty good read about what has been studied so far and what the results say.
Yeah.
Representative Murphy.
Thank you, Mr. Chair, and thank you for that. I just looking for the other nerds, right? Like me. So the last question I have, and you might not know the answer to this, but as I'm listening to the testimony, I am just curious about if crumb rubber, if the science concludes that it is safe enough. Are there explorations of means of using it that capture some of the off-gassing that we're hearing about today? Are there means to use it that would render it safer if kids are playing in it? I'm just thinking about the parent whose testimony today is, striking, and I think we should pay attention to that.
Mr. Ines.
Chairman, Representative Murphy, I don't have an answer for you. It's a good question, though, and I'd be happy to follow up, but I don't have an answer for some kind of next generation of synthetic turf that may not have such the thermal dynamics of heat. So, I don't know.
All right. Thanks, Mr. Chair.
Representative Quam.
Thank you, Mr. Chair. Mr. Ines. A couple of previous testifiers, they mentioned they measured 150 degrees, and another testifier mentioned 185. I assume it's in Fahrenheit. How do you respond to all the burn cases from these high temperatures?
Mr. Ines.
Chairman, Representative Quam, here's what I would say. Minneapolis is currently reviewing their recommendations on how they should deal with crumb rubber and crumb rubber playgrounds. It's a little more of a symbolic gesture because all those facilities come under the jurisdiction of the park board and the school district. But they're looking at recommendations, and it was interesting on the citizen advisory committee that's doing kind of the due diligence on this. There were a number of people on there who had recreated extensively. They're former soccer players, I think competitive players, on synthetic turf fields, and they never raised any concerns about these second-degree burns or any of these burns. It does get hot in certain temperatures, but people have actually been on the turf. People experience years of experience on it. That was never a concern for them. They talked a lot about the attributes of the material, especially in Minnesota, but that, the temperature can get hot. But I've also heard many urban myths. Like there was testimony given by one of the people on the council that, well, the Minneapolis Park Board has to go out there and water down the field because they get so hot and so dangerous. Well, the Park Board was there, and they said that's never happened. We've never had to douse the fields with water in order to make them more temperature appropriate. So not a complete answer for you, Representative, but the people I've talked to and the people who have weighed in on this, who actually have played on the surface, have not mentioned those concerns.
Representative Quam. Representative Grunhagen. All right, members. Yes, we are past our time for the hearing. The chairman of the tax committee is eagerly awaiting the warm seat that I have left him, and we do have two testifiers still to this bill, and so I'm going to lay the bill over. So House File 1502 is laid over, and we are adjourned.